Okay, so we're going to go over just a few things that are different specifically about the assessment of your geriatric patient. So first thing first, getting old is not a disease, okay? Illness is not an inevitable part of getting old. So we don't want to, I'll say, give credence to the thought that complaints from a geriatric patient is just because they're getting old, okay? Doesn't work that way. Aging is this normal process that's continuously happening and in and of itself does not produce symptoms of disease. So if they're having signs and symptoms of an illness, there's an illness causing it, okay? The biological effects of aging are just normal wear and tear. There's another kind of widespread incorrect belief that older people are hypochondriacs and they have all these things wrong with them. Hypochondria is actually less common in geriatric patients. Older patients tend to not complain even if they have real symptoms, and they tend to downplay it if anything else. So if an older person calls for pre-hospital care, there's usually a real problem. Now, it may be difficult to get to what that problem is, but there's usually something going on with it. So it is important to be able to differentiate your signs and symptoms from aging from the disease process, okay? It's also important to realize that the signs and symptoms that you might normally expect in certain circumstances, i.e. like heart attacks, you expect chest pain, right? You may not get those signs and symptoms. They're going to be altered because of the aging process. Their pain receptors may not be working quite as well, so they may not feel chest pain. They may have just a little discomfort or upset stomach feeling, and that's the only indication they get. Your pneumonias may not have a fever. Uncontrolled diabetes, is more likely to present as like the hyperosmolar non-ketotic coma than it is to present as a DKA. Some acute illnesses may just present just as a delirium. That's the only symptom you get, but there's something seriously wrong there. So it's real important to understand that there are certain things that happen, but you're not going to get all of the classic signs and symptoms that we normally might look for. Something else to think about is multiple pathologic conditions, meaning they may have multiple problems going on, and this can present problems for the patients and the healthcare provider trying to figure out what's the problem. Signs of one or symptoms of one disease may hide or change the symptoms of another disease or condition. Maybe somebody who's got really bad arthritis and they've got severe pain from this arthritis, they don't realize that some of that pain's being caused because they've got a thrombophlebitis going on. They've got inflamed blood vessels or a clot or something like that. So you can kind of hide and let one illness become a really bad problem before it gets figured out, if you will. If you have a functional problem in one body system, that can have repercussions throughout the whole body, having this like kind of domino effect where one thing doesn't work right, now the rest of it stops not working right. It can be kind of hard sometimes to figure out which condition or problem is causing which symptom. Having all of these comorbidities can make it a little more difficult to treat an acute problem because of contraindications in medicines and needed dosage modifications and things like that. It just makes it a little more complicated. So talking about scene size up, of course, ensure scene safety, right? Take standard precautions. Now, I want to throw this out here. The vast majority of geriatric patients are not going to hurt you. However, don't let the fact that they are elderly or geriatric make you think that they can't hurt you. I remember vividly had this fellow, I was an EMT working with a paramedic, and he was kind of cocky, thought he was, hot stuff. And there was one old lady at this particular nursing home that was notorious for bopping you in the face. If you got in her space, she would just rear back and cold cock you in the nose. I tried to tell him this. I was like, man, she's going to punch you. You better say, oh, no. It's our old ladies love me. Right? And sure enough, he got down and he knelt down right in front of her. I mean, we're talking like he was a foot in front of her, talking to her, kind of condescending. And before you know it, she went bop, popped him in the nose. And he was like, said some words I can't say. But they can potentially hurt you. So don't let the sense of a geriatric, look like granny and grandpa. Don't let your guard down. With that said, scene safety, standard precautions, right? Look and see, mechanism of injury or illness. Nothing really has changed there. Look for clues. Figure out how many patients we have and all that kind of stuff. But there are some things that you may have to kind of alter your assessment with the geriatrics. If they have sensory alterations, maybe their verbal communication, their auditory, maybe they can't see as well. So we may have to kind of change how we approach the assessment. I also am looking for things that may be a harm for that patient. If the patient's called us 5 times because they keep falling on rugs, well, guess what? I'm going to look and see how we can make these rugs not fall and slip anymore. If they're walking on socks and wooden floors, look for things that they may not have thought of or that might help them. That could be an environmental issue with them. Speaking of environmental, there's this thing to help do your primary assessment, besides the whole ABC, but just the overall assessment of the patient in general. There's this thing called the GEMS diamond, and what it is it's used to kind of form your overall general impression of this patient, right? So what we're looking for is the general living conditions. Do they have family support, their activity level, their medications, their overall appearance, nutrition, health, cleanliness, personal hygiene, their attitude, mental well-being, that kind of stuff. So the GEMS, specifically, the G is for the geriatric patient, recognizing that this patient is a geriatric patient, which means we're going to have to maybe alter our assessment. Maybe some of the problems that might happen may be atypical presentation, that kind of stuff. The E is for environmental, and this one, something I really like to look at because you may be the only person that gets a look in their house that could get them and recognize the need for additional assistance, because a lot of people are too proud to ask for help. So the environmental is looking, is their house too hot, too cold? Is it well kept? Is it secure? Are there hazardous conditions that, are there risk factors that might cause future accidents, that kind of stuff? Are they able to keep up and take their trash out? Does it look like they're eating adequately? That kind of stuff. All right, then the M is for medical assessment, so keeping in mind that they may have numerous health problems, they may have numerous medication, making sure that they are, you're getting a good, accurate, thorough history. And then social, people don't always think of with pre-hospital setting, we don't think about the social aspect of it, but once again, we may be the only ones that can get that inside scoop, if you will, onto what's going on with this patient. So this is seeing, do we have a social network? Do they need assistance with these activities of daily living? And maybe we can give them some references to Meals on Wheels or things of that can maybe help improve their quality of life if they're staying independent. Now, moving on to the actual primary assessment here, so our ABCs, right? So we're looking, and the big thing is to think about the changes that occur with the aging process. Anatomically, in geriatrics, they're more predisposed to airway problems. They lose that gag reflex, the normal swallowing mechanism, so they're more likely to choke or aspirate. We talked about, and if you go back and look at the anatomical changes with the respiratory system, all that stuff, the circulation, we talked about that. So all of these things really can alter what you find with your ABCs. If they've got dentures, that could be an airway occlusion. You may need to suction more, a lot of chest wall stiffness, brittle bones. There's a lot of changes physiologically that happen in dealing with your ABCs. All right. As far as transport decision goes, we want to look for any, of course, life threats, right? We make sure that we're treating them to the best of our ability and giving transport to priority patients, right? Something to think about is that these geriatric patients will easily decompensate, typically, okay? So, general weakness or dizziness in a younger overall healthy person may not be as significant of a sign, but in a geriatric patient, that could be a very serious heart problem. So you don't want to underestimate the severity of their injury. Consider early ALS support and transport immediately if possible. And if possible, try to transport them to a facility they've been to before, if they've been somewhere before. Now, when it comes to history taking, you've got to use those good communication skills. All right, you've got to introduce yourself. You've got to use respect. We're not going to do honey, buddy, grandma, dear, all that crap. All right, we're going to be respectful. We're going to get their trust. We're going to speak slowly, distinctly, and respectfully. We're not yelling at them. We're not over-exaggerating what we're saying. Don't be a butt, all right? Just speak slowly. Give them time to answer. Try to get the history from the patient directly whenever possible. And when you give them a question, give them time to process it and answer it, okay? Make sure you get that thorough history there. If you have a plan of action, explain the plan of action to the patient and make sure that you preserve their dignity. Comprehensive history needs to include everything that's pertinent, which means it may be a lot of stuff there, okay? But at minimum, we need the chief complaint, the present illness or injury, any pertinent medical history, and the current healthcare status and needs, i.e. if they have a DNR or a power of attorney, that kind of stuff. The pertinent history stuff, maybe diet, medication, smoking, drinking, sleep patterns, and other factors like that. Bring a medication list. If you can't bring the meds, bring a medication list. And a lot of elderly people will actually have a full list with their dosages and everything when they take them and whatnot. So one or the other, you need to take it with you because there's usually going to be a fair amount. Now, with the chief complaint, sometimes this can be a little bit more difficult with your geriatric patients because some of them may think that their symptoms are just part of getting old. They may not mention legitimate signs and symptoms because they don't want to be labeled a hypochondriac. Some of them don't want to tell you what's going on because they don't want to go to the hospital, because if they go to the hospital, they lose their independence. They're afraid they may get stuck in a nursing home and not come back to their home. So they may not, tell you how serious some things are and just kind of give you some vague answers. But make sure that we keep digging and really find out what's going on with the patients so we can get them to the appropriate care.